Hey guys, welcome to the Corrective Culture podcast. Usually Jake does the intro, but I'm going to do it today. We have Dr. Shirley Sahrmann on. It's crazy for me actually, Shirley. I've listened to probably every podcast you've ever been on, to be honest. You know when it's like when you're talking to someone you know so much about them and they've never seen you. That's what this is like, and I'm sure you get that all the time. And and basically, what I've taken from you, because we're in the Czech Institute and a lot of our mentors have quoted your work for a long time, right? So we heard your name pop up all the time. And then, but as you go through the field, you can only learn so much at a time. And then I've come across your book, Movement System Impairments. And it was one of those, I feel like when you take from these, even like mentors you've never seen, you take bits and pieces from everyone. And you start to see how everyone's got their thing. And then my goal for that is just to integrate it into however way I can express it in what stands out for me and my passions, right? And what I've been listening to your podcast recently and about like you on other people's podcasts and just talk about how you were one of the original ones to make it known of like looking at movement system impairments, I guess instead of diagnosing the tissue itself. And instead you've diagnosed, that tissue, why is that tissue like that? You know, what movement has occurred for that to happen? And really what I see in myself, in you is a curiosity. I see a curiosity that's never left you, you know, and the curiosity is everything, you know, because when you see something, I can see you ask why, and why is that like that? And what I'm blown away now in the way...
Very insightful.
Yeah, and what we can learn now from online, it's amazing what we can learn online. Like I know we can sit down, do a class and whatnot, which is always gold, always in person is great. But I watched a video of you, I'm not sure if you've even seen it, of you doing an assessment on this guy in a class. I'm not sure where the class was, it's on YouTube. And I think he has some back like pain sort of, and he was pointing to his like QL area on his left-hand side, and you were just running the class through an assessment.
Tim Ferriss?
No, it wasn't a Tim Ferriss one. It was like,
okay,
you weren't even looking at the camera. It was someone in class filming you.
Just taking a video?
Yeah, taking a video. And then I saw how your brain, I saw the way you were thinking. I saw, okay, well, that's that left hip pike's creating a side bend to the left, and then this is the TFL doing it. I saw you splitting the legs apart and seeing what that did to the pelvic height, or bringing them together and seeing if it made it worse. And it was so exciting for me because it wasn't like, it was like left brain and right brain at the same time. That's what it looks like to me. It's like you're going creative, but you also, there's a path to it. There's anatomy to it. There is that this inserts into that, but also thinking, all right, how can I change the body, and then start to know, what's short, what's, you know, what could be restricting their range of motion, or what's possibly creating their pain. And it was just so exciting for me. I could watch that 3 times over, you know?
Well, I don't think you need me. I'll just let you go ahead and explain.
Yeah. No, we need you. We need you. So did you graduate in 1958? Is that right?
I did.
And
I'm still here to talk about it.
And that's amazing because my mum...
Well, I'm 87 years old.
Nice. Yeah, wow. And we'll get into that. We'll get into the secrets of that. But that's the same year my mum was born, right? And she just turned 67. Oh. She just got her pension. And so she's
87?
67. 67.
Oh, yes. 20 years.
Yeah,
20 years earlier.
20 years. Yeah.
That's a whole lifetime difference.
Yeah. So basically, I'd love to ask you, like, what was the field like when you got into it? Like, what you were taught, is it rapidly different to what they're taught now?
Yeah, if you sort of looked in the book a little bit, I have sort of divided up into 3 eras for the profession. And so when I first started, it was actually, I'm old enough that I saw polio patients.
Mm-hmm.
Wow.
The vaccine had just come out, but it was a very different world because you knew what the problem was in so many ways. In other words, the muscles lost their innervation, so the ones that were left developed contractures and muscles were weak. And And so you did everything. The trickiest part was what we called muscle re-education, which was attempting, the worry was that strong muscles would overpull weak muscles and the weak muscles would never come back.
Mm-hmm.
So, so, so that was my early introduction. But then the vaccine came out, and happily, in many ways, those patients all went away. And then it became all about the neurological patient, the patient. And because, I mean, this might be interesting to you that when I was first working, any male over 6 foot that was rear-ended became quadriplegic.
Wow.
Because there were no seat belts, there were no headrests. And so boing, the little head acted like a bowling ball going back and forth.
Wow.
And so we had a lot of young people that were quadriplegic, and they had just begun to be able to save their lives. And so that kind of spinal cord injury, stroke, head injury. So that was a big change in practice to the neurological central nervous system. And what was probably why I started trying to think more about what I was doing and why is because everything we learned to do for the polio patient was contraindicated in the neurological patient. So it's like, what do we do now?
Mm.
That was the big transition.
Wow.
So, and in fact, I mean, I tried to figure it out, but I felt in many ways I was sort of a frustrated medical cheerleader. Come on, you can do it. Let's go. But I didn't know what I was doing. And finally, after 9 years, I admitted to it. And so then I went back to school to get my PhD. And I was going to solve the problems. There's a phenomenon in when you have a central nervous system lesion called spasticity.
Mm-hmm.
So it's really hyperactive reflexes that make muscles work when they shouldn't work. And in fact, that was one of my dilemmas. In the polio patient, they were missing a lot of muscles, so I understood why they didn't work. But in a neurological patient, they had all their muscles, but they were out of control. And it was like almost every patient was different. There was not like, this is the way it worked. So anyway, I mean, I learned a lot. A lot about people, and I learned a lot about neurological disorders. And in those days, it wasn't all about money. So we had time. Patients stayed a long time. We could spend all day with them. And that was, now it's a push for productivity and how much money you can make. So it's a different world.
Yeah, right.
So anyway, so as I say, that was after 9 years of practice, going to school, got my PhD, and then and that took about 6 years, and I actually did more animal work. In fact, when I finished my PhD, believe it or not, one of my big questions was, how does the brain control movement, and what's this about spasticity? So I actually trained monkeys and recorded from their motor cortex while they did a task with their foot. And then the idea was to go back, put a lesion in their descending pathway, and see how the brain reorganizes itself.
Wow.
I did not push back many frontiers of ignorance, so it was a lot of time spent without a lot to show for it.
Yeah.
But I learned a lot about the nervous system, and that's what came to prove particularly useful in this whole thing about movement.
Right. So in regards to like the PhD, like 6 years, like what is mainly to get that, what is your time filled with? Like, was it guided? Was it guided by your curiosity, or did you have set things that you were told that you had to start learning or do, or what was that?
Yeah. Well, you had coursework to take.
Yeah.
So, in fact, that was part of what was challenging for me, because I had severe cerebral atrophy from not having to think in many ways for many years. And then one of the requirements, in fact, it's kind of funny, when this was in January, and I went, and I was not qualified to be in the program. It was very funny, but they had just started this program in neurobiology, and I went to the doctor that was head of it, and I said, I think I'd like to enter this program. And he said, well, just find yourself a mentor. So I went to this neurologist that I had argued with about how to care for patients. And and he had been to a meeting where there were physical therapists, and he said black magic, nonsense crap,
Yeah.
that there was nothing that made sense to him that physical therapists were doing. So then he said, okay, I'll take you on because somebody's got to straighten you physical therapist out.
Right.
He was just quite a character. So anyway, he did. He took me on, and so I had coursework. In January, I just jumped right into the biochemistry class, and it was kind of funny because while they're lecturing and they're talking about ethyls and esters, I'm thinking of all the girls I went to school with, and not about chemical things. So the first test, I think the only thing I got right was my name because they asked me early.
Yeah, right.
And so I spent the summer taking chemistry, getting caught up because where I left off was only like the first 3 weeks compared to what biochemistry had gone to in those 9 years. So anyway, so I had things like biochemistry, physiology, um, and beside the coursework, statistics, etc. I also did some laboratory work with different people, and then the last part of it was working on your dissertation, your research project. Yeah.
And was that your influence, like your movement based diagnosis? Is that what you were moving
Now
into?
it was what I was interested in because this was still the bent was toward the neurological patient and trying to understand the disordered motor control of those patients.
Right.
I mean, it was about movement, but more the neurological control of movement.
Yeah.
And also, I had become sort of convinced that that reflexes became very stereotyped. So I did a repeated long-term stimulation of cats that I had decerebrated and looked to see if the prolonged stimulation would result in a significant reflex. And that's sort of the way it turned out. But um, and the neurologist that took me on was very kind, and he actually hired me then half time, and he's the one that set it up so that I was recording from monkey motor cortex
Right.
for probably 17 or 18 years. But meanwhile, I was also in physical therapy, so it was half time in both places. But the neurological patient, sort of told me, and I think this is a big part of where I am now, is number one, that just strengthening a muscle doesn't solve the problem. You've got to change the way they move.
Hmm.
And that's a joint effort of the nervous system and muscles. It's not like the brain sits up here and says, go and do this. It's not like the muscles say, I'm strong and do this. There's a neuromuscular pattern of activation. And, and see, and so, um, and then also this thing about, well, one of the things that's intriguing is why do normally innervated muscles become weak?
Hmm.
In other words, the kind of patients you see with musculoskeletal disorders, for the most part, have some weak muscles, but it's not like polio where they had a loss of innervation. It's not like a trauma in which something killed it. It's it's like it's in the pattern of activation.
Mm.
And and I find this, I mean, it's kind of super running through my head, so you'll hear the end before the beginning. But what's really interesting, I'll put it this way to you so you understand. When you see somebody standing, and of course, I'm obsessed about looking at people and what their alignment is and how they move. So the question to me was, why does somebody stand the way they stand?
Mm.
And now I know in most of the people I've dealt with in Australia are very physically fit. So so most of them have good muscles. But in the United States, standing up is an exercise.
Right.
Uh,
Yeah.
and so we have people that have ultra marathonists and that who have too many muscles, and then we've got people that don't have them working. So the big thing, and this was another big part of the aha moment, is realizing about muscles' passive tension.
Mm-hmm.
Okay. In other words, I think I used to think it was only the hamstrings that everybody wanted to stretch that had passive tension. But muscles are like a spring, and the bigger they are, the stiffer they get. So when you look at, and here's the other thing, is the metabolic set of the body is to minimum energy expenditure.
Mm-hmm.
So if someone's standing, and if you can imagine if they have a large abdomen and their pelvis is tilted, it's because they're resting on the passive tension of their abdominals.
Yeah. Okay. Yeah.
Even though there's not that much, but that's what allows the fault
Yeah.
of anterior tilt, etc. And so to sort of fix that person, to correct that, because it'll give them back pain, is they have to shorten their abdominals and improve the tension.
Mm-hmm.
So it holds the pelvis in the right place. So in the past, people would have looked at somebody like that, well, it still goes on, and think they should stretch their hip flexors. But that's not the secret at all. The secret is shortening and stiffening the abdominals so that spring pulls more strongly than the hip flexor spring.
Mm-hmm.
Am I making any sense to
Yeah.
you?
Yeah. So sort of like they're resting off their abdominal tone, and I guess their hamstrings will be taking passive tension also while their butt is sticking out. But it's not about stretching the hip flexors. It's a tension problem within the, I guess, the lower or the abdominals, and the hamstrings would be put on tension too, wouldn't they? Passively.
They would. They would. But if they were short enough to pull your pelvis out of tilt, you'd never take another step.
Right. Right. So
You would have a great big energy demand on you to be able to take a step. No.
yeah.
And then the other thing that's interesting is that if you take somebody and they sway back, so their shoulders are behind their hips.
Mm-hmm.
Yeah, I don't know whether you've ever noticed, but their buttock muscles go away.
Yeah. Yeah.
I call it missing for lack of action. and and this was also something I learned from taking care of paraplegics with the central nervous system, because if you're swayed back, your line of gravity is well behind your hip joint.
Mm-hmm.
So you don't need those muscles.
Yeah.
So in people that have the missing buttocks, then their hamstrings are usually overdeveloped, more overdeveloped, because they have to do the job that the gluteal muscles aren't doing anymore.
Right. So they're doing the job of what, that little bit of hip extension they're getting? Is that what you mean?
Yeah. In other words, it plays into the whole problem. You don't have a balance between musculature anterior and posterior.
Yeah.
And this is kind of a really overlooked thing in my mind, is that the real value of having good alignment, as much as optimal alignment as you can have, is that if you lean back, your abdominals work. If you lean forward, your back extensors work. Your gluteals work. You lean back, your hip flexors work. So you're constantly alternating the use of muscles, mm-hmm. which is what provides for musculoskeletal health. But that isn't the total way things work. So starting with my example, if the abdominals aren't very good, and I have slides of all of this that in a PowerPoint presentation. So if you take one guy that looks like he has bulging abdominals, another guy that's well built, and you have them do exactly the same activities, bending forward, come back up, rocking on their hands and knees, laying down, lifting their leg up, they use total different muscle strategies.
Right.
So guess what? The guy with missing abdominals uses his hamstrings, sort of like you suspected,
yep.
to push down, raises the leg up. He uses his abdominals all the time to control, his hamstrings all the time to control him.
Yeah.
And the other guy shows a totally different picture. So they're doing the same thing, which is why innervated muscles get weak. The body wants to be very efficient, mm-hmm. very efficient, even at the cost of good musculoskeletal health.
Right. So It's all energy.
Yeah, I mean, yeah, yeah, yeah.
Yeah, that's really interesting. Like, so therefore, because you know how we're taught, like I guess we learn to, I guess, walk from our parents, right? Like you can see that, you know, you see a son and a dad and they're walking the same, or a daughter, you know, you see it so often. And I remember one time I was at the beach and I saw a girl that was, I don't know, she looked Argentinian, and there was another girl that looked like, I guess, European. But I was like, they're walking the exact same way. They got to know each other, right? And then they walked and they met each other on the beach and then went up to the parents. So they must have, you know, got a genetic from this parent and that parent, but they walked the exact same way. So
That's
therefore I
interesting.
wonder, like, okay, I guess we learn to walk from our parents, right? And within our structure. So therefore, do you teach people then how to stand or bring that awareness to standing?
Well, it's interesting because one of my favorite questions to patients was, "Who taught you to walk?"
Right.
And and they say no one, and I say that's the problem. It's a good thing
Yeah.
you're
Okay.
now. So yes, and over and above your observation, I mean, the thing is when you go through physical therapy and you take kinesiology, you learn all the factors in what we call normal gait,
Mm-hmm.
which is really an average of all kinds of variations of gait. It's not really normal; it's the average.
Yeah.
But what's so interesting to me is you can recognize somebody at a distance by how they walk long before you see their face.
Definitely.
So what that says is we aren't all using the same strategy, or we would all the, the sort of the kinematics of it are somewhat similar, but it's highly variable, or you couldn't do that.
Mm. Yeah.
And
So
and so so when I watch somebody walk, I know which muscles they're using too much and which ones too little, etc. And then there's structural variations too. As you, I'm sure, have observed, not everybody is built the same.
yeah. Yeah. Definitely.
Yeah, some people are tall, some are short. Some have Men have big shoulders, small hips. Women the other way around. Some people have what we call knock knees. Some people have bow legs.
Mm-hmm.
Knock knees more in women, bow legs more in men, and that has to do a lot with what the structure in the hip joint is. So all of those are also factors that influence how you move.
Right. I've always wondered about I like to think about evolution a lot, right, with all this sort of stuff. And I've always wondered these structural, like say a retroverted pelvis, what is the benefit of that? Because I know there's a symmetrical norm for things, right? But I always think back to, have you ever reflected on, like, okay, why does some humans, men, and when I say men I mean me, have say a retroverted pelvis, or females the opposite? But what's the benefit of that in regards to not even sport, but I guess human evolution? Like, I was wondering, I tie it back to, like, is it better for like dragging the animal home through the snow or something? You know what I mean? I don't know. I start thinking about these things, about why you would want a little bit of external rotation in those femurs. Have you ever thought about that at all?
Let me be clear about what you mean by a retroverted pelvis.
Yeah.
The pelvis to me is, when you say retroverted, it means that it's tilted backwards.
Oh,
It's a
okay.
posterior. And then there's a structure in men, we call it a tall pelvis. So it's where this was easier to assess before the fashions changed. You put your hands on the top of the pelvis. And if it's posteriorly, well, you get an idea of whether it's posteriorly tilted. But many men come with this tall pelvis where the top of the pelvis is at least a couple centimeters above the belt line.
Mm-hmm.
And so they have a flat back and a shorter trunk.
Yeah.
And they're more prone to getting back pain.
Okay.
And and the reason is their lumbar spine is flat. It doesn't have the traditional curve.
Yeah.
Now, which monkey those people came from, I don't know.
Yeah. True. Yeah. Yeah. Okay.
I mean, yeah, and of course, been a lot of evolutionary changes, going from the quadruped position to the upright position,
Mm-hmm.
and the sort of transition in the apes as they walked more upright. It wasn't very efficient for them.
Mm-hmm.
So, but I've never studied anthropology, so I feel happy to recognize what I can in real life human beings. So
Yeah. Yeah. That's nice. So, in regards to like where was the first shift where you started looking at movement as a diagnosis? Like, did a mentor start to teach you that, or was that your own curiosity that brought that in?
no, no, no. I mean, as they say, even with the neurological patient, I was trying to figure out because I had this one orientation and now I had to have a totally different one.
Mm.
And so I was trying to put the pieces together of why did some people have, for example, you can have a patient with a stroke who can sit and straighten their knee out, but when they go up to stand, it doesn't work. You can have a patient that goes the other way. They can't straighten their knee out and they stand up and it works.
Mm-hmm.
So what was that all about? How did all the pieces fit together? In fact, one of the things that's a big part of my assessment that I got started then was having people in the quadruped position on hands and knees. And that's very useful to seeing any asymmetry both in the trunk as well as in the hips. And then if you have them rock back, you watch how the movement is asymmetrical.
Mm-hmm.
And I'll give you a specific example with a musculoskeletal patient. And I think it's one of the reasons why people get ACL tears.
Okay.
You know what I mean? Anterior
Yeah.
cruciate ligament tears. Is because if the deep hip muscles that you have underneath the gluteals are the little, and this is, I'll take it on to Australia in a minute, the little deep muscles.
Mm-hmm.
And they're the ones that prevent your thigh bone from rotating inward.
Mm-hmm.
Okay. So one of the phenomena is the gluteal muscles, like the gluteus maximus, can become so strong that the little deep ones get weak. So if you put somebody in quadruped and you have them rock back, that hip will medially rotate.
Mm-hmm.
It will turn in.
Yeah.
And the issue with that is it's turning in at the knee because it's one solid bone. And that rotation at the knee is enough to start compromising the ACL, the ligaments in the knee.
Yeah.
So that's, to me, it's an indication of the problem is with the deep muscles. And in the world of physical therapy and exercise, and I'll say this for every exercise, and the Australians have been very big about this. Do you know who Gwen Jall or Paul Hodges are?
Yeah. I know Paul Hodges' work. Yeah. They're Brisbane, wasn't he?
Right.
Yeah.
And Gwen too.
Yeah.
Yeah. Well, in some ways, they took the lead in putting research behind to show that these deep muscles are ones that don't stay strong enough. And the problem is it's very hard to get them to work without making the bigger muscles also work.
Mm-hmm.
Do you know what I'm?
Yeah. Yeah.
So Gwen has, like, I don't know, she said 9 pages of exercises for the deep neck flexors. A good everyday example for you is rotator cuff tears.
Mm-hmm.
So the deltoid I consider the evil muscle of the shoulder because it can do so many things, and then as it's doing it, the deep muscles stop doing their thing well.
Okay.
And then the trick is, how do you exercise them without also at the same time exercising the big muscles?
Yeah. Yeah. So are you, is that like a, say, posterior deltoid doing too much work for the infraspinatus? Is that sort of what you're leaning on?
Well, it kind of middle deltoid because that's more of an abductor. Posterior deltoid because it helps with the rotation from the supraspinatus.
Yeah.
But it's all of the deltoid. The anterior deltoid medially rotates and flexes.
Mm-hmm.
posterior deltoid extends and laterally rotates, and then middle deltoid sort of abducts.
Yeah.
They all can work together to abduct. Yeah, and then doing those functions, and it gets so strong that all those little rotator cuff muscles that are supposed to control the head of the humerus can't do it because the deltoid has gotten too strong.
Mm.
Do you have an example of like a couple exercises for the hip? Like I know you're talking about in the quadruped position for the hip and for the shoulder as well to get those inner unit muscles. Like is it like the horse stance series, or is it?
Okay, so
Or more isolated.
let's talk about the shoulder.
Mm-hmm.
So one of the ways that we found successful is if and it sounds pretty hokey, but it seems to work that way, is that I have people think about having their fingers go to the ceiling while they're keeping their shoulder girdle laterally rotated. You just abducted. You got to get it in front of, bring it. That's it. And then fingers going to the ceiling. That's it. And the reason for doing this is because when the body's doing a motion, it recruits smaller motor neurons first.
Mm-hmm.
And because, like if you're just standing around with your arm here, you're going to be using these muscles in your shoulder, and you're probably using your hands. So you've kind of built up a greater link between the rotator cuff and your fingers.
Right.
Do you see what I mean?
Yeah. Yep.
So if I can get people, and then even though the anterior deltoid flexes, it medially rotates. So by having them laterally rotate,
Yeah.
I'm not using it. By having them flex, I can't use posterior deltoid, even though it laterally rotates. And I don't need middle deltoid because I'm not abducting. So it's this kind of motion until they can prevent it from going like this.
Right. Okay.
Ooh. Yeah.
I bet that
Like-
gets fatiguing too. Like, you know how
Yeah.
you get people that are like can lift a whole lot of weight, but then you tell them to put their arm in front of their body for 30 seconds and it all starts shaking.
Yeah, I think like
Yeah.
the check press, would that be like an example of that exercise?
Well, I
'Cause
guess-
you're kind of like bringing it in, or do you have to have like, is it more like a?
Like, would you
No,
load that at all or no?
no, you don't want to load it.
So it's
No,
more
yeah.
neurological.
First, you want to see that the motion's performed. You don't want anybody going like
Yeah.
this or
Yeah.
no. You want to see an optimal performance before you start to load it.
Yeah. Yeah.
If you load it, what you're going to do is build up the big guys
Yeah.
and not the little ones that control things.
Mm.
Yeah. Okay.
And then at the hip, it's also another very interesting thing, because the gluteal muscles. I don't know how much you know about all this anatomy things, but the gluteal muscles turn your hips out.
Mm-hmm.
They're lateral rotators, as well as extend. Okay, but when you're sitting, when your hip is flexed, they become medial rotators.
Right. So when your hip is flexed, the gluteal becomes a medial rotator. Really? I thought it was just like piriformis, and I didn't know the That's amazing.
No, the piriformis changes too.
Yeah. Yeah.
Yeah, a little bit. It's not, but all of the gluteals do. The gluteus medius, gluteus minimus,
Mm-hmm.
gluteus maximus. So if you were sitting and I was testing the strength of your medial rotators, so you turn your leg in and I push on it, they would be strong.
Mm-hmm.
If you had your legs straight and I tested it, I mean your hips straight, they would be weak, the medial rotators.
Yeah.
So when you're sitting and the gluteals become medial rotators, those little deep muscles have to be able to do more.
Mm.
They have to be really strong because now they're the only way you can control your hip lateral rotation.
Right. So therefore, that's the way.
That's why in quadruped, when the femur, when you're flexing your hip as you rock back, and if those deep lateral rotators aren't strong enough, they're going to let your hip turn in,
Mhm.
and then it's going to do a number on your knee. And I think that's one of the issues that contribute. It's a sign that they need to be better to protect your knee.
So when you
And
when you assess that in quadruped, do you just have your hands on sort of the front of their thighs and just trying to feel if it immediately rotates, or you?
I put my fingers on the region of the femur at the greater trochanter.
Okay.
You can sort of grasp the greater trochanter, and you'll feel it, like the hip that hurts will turn in like that.
Wow. Yeah. How cool is this bringing this? There's like, even what you're talking about there, like bringing touch and feel into it. I feel like that's out or phasing out of the industry almost. I know it's coming into certain sectors with your education, other people's, but it's not taught really, what I know of in sort of local university here of trusting just something as basic as that as your hands. Like that's a sort of a big lever too. Like most people will be able to feel that, right? But that's not something that's very taught. Like everything's so paper now. It has to be on paper.
Well, right now in physical therapy, it's all about pain in the brain.
Yeah.
Which kind of upsets me. Because they haven't gotten the movement part, and I don't want to be a psychologist or a social worker. I want to do what I'm supposed to do well, and if they need a psychologist or a social worker, they should go there.
Yeah.
Plus, I think the way I handle patients, I have a whole lot of, it's already built in that I'm paying a lot of attention to what that patient is like, because. Well, let me back up for a minute. One of the big trends that developed after this neurological patient, and it's all because of Australians going to England to learn from a physician by the name of Syriacs. They became manipulative therapists. I don't mean behavior-wise, but we call it press and guess.
Yeah.
But it was all about moving the joint. The irony of where I am in these problems is, it's not that the joints don't move, it's the joint that moves too readily that causes the problem. It's what moves that hurts, not what doesn't move. So anyway, that became a sort of a big thing in the musculoskeletal world. And then it migrated from manipulative therapy to manual therapy, so that there was some addition of exercise. And here's to me the big problem with the profession is that, and I can understand how it got there, but the whole emphasis of physical therapy is knowing techniques. Like, do you know how to do Mackenzie, who's a New Zealander? Do you know how to do PNF? I mean, it's all about a treatment technique. And then knowing that treatment technique is supposed to be something that leads you to the cure. And what I've been trying to push is that you got to understand how movement causes the problem. It's you're treating something, but you don't understand where it came from. You're not fixing it. You're just fixing supposedly this joint, which I also believe is moving too much, not too little, too readily. And so that's part of what my endeavors are, is to try to get people to look at a content area rather than be identified by their skills.
Yeah, it's like
Do you know what I'm saying?
I know what you're saying. It's almost like I feel like the world's leaning that way in regards to the normal medical profession. Like we're starting to see it. Everyone knows, okay, you can't just throw 20 pills at a problem. Like there's a reason why they have an illness, but no one. It's not common to reflect on that with movement yet. Because the same thing. Why does your knee hurt? You got to ask, why does it hurt? Not like, why do I have a tumor in my lung when I smoke 30 cigarettes a day, and they don't worry about the cigarettes. A similar concept, and same in regards to movement. So that's it just it's sort of obvious, right, when you say it like that. Sometimes it's so simple.
It is, and you see, and I think all of these problems, they start early, and I think there are signs before there are symptoms.
Okay.
Just like you're talking about, and so looking at those now, the tricky part is that because there is individual variation, how do you sort out when it's going in the wrong way versus it's just an individual variation?
Yeah.
that's a bit of the challenge, um, but with enough experience. And then the other thing that I'm pushing, well, there are two more things. One is a systematic exam, so that, and to me, this is why it was pretty effective in dealing with people as personalities. I didn't have to think about what I was going to do next. I didn't have to think about what does it mean, because I have a whole backlog of information about that. So I could watch, how's that patient reacting? Do they care? Are they scared? Do they not want to know more? Do they want a lot of detail? Will they never try to do an exercise? Do they want to do it 3 times a day? So, and then the other way the exam goes is that you have them do their preferred movement. So like if you bent over and it hurt, and then I would show you how to bend over differently so it didn't hurt. So even if you're in bed and rolling and it hurts, show them how to roll over so it doesn't hurt. So that you're putting the patient in charge of their pain. And that's much more effective than, I don't know what I did and I don't know how to change it. And then it goes on from there.
Yeah.
So the one, by addressing people this way. And then the other thing that goes with that is the systematic exam leads to a diagnosis. So that's what you saw in the book. And physical therapists are not using movement-related diagnosis. They say we're diagnosticians, but I say show me the list.
Yeah.
And they haven't done that yet. So, yeah.
Yeah, it reminds me of a story. One of Jake's old mentors, I was watching her work with a client, and he was doing like wall balls, throwing the ball at the wall and catching it and sort of decelerating and going out because I forget what his sport was. But he goes, "Oh, it's hurting my knee. It's hurting my knee." And she goes over and puts her hand on his shoulder and she goes, "It's your knee. Stop it from hurting." And then he's like, "Oh yeah, if I move my knee just this way a little bit, it doesn't hurt anymore." So the point of that was, it was falling immediately every time he did it, but he was sort of looking for her to say, "What do I do?" Instead of like just what do I need to do in my body so this doesn't hurt anymore? And just that self-reflection of looking at it from empowering, basically what you're talking about. It does empower the client when you teach them how to do the thing they love. I remember I heard a story of this lady. She thought she had to go into a retirement home because whenever she sat down, she couldn't squat, basically, right? Every time she couldn't get up and down off the toilet. And then he goes, "Show us how you squat." And then she just didn't know how to squat. Her legs were shaking, everything was going off. So he's like, "Put your hands on your knees, sit your butt back, like glide down." And then she could get down and up without pain. And she goes, "Oh, I don't need to go to the retirement home now. I can do that." And he's like, "There you go." Like it was the movement instead of isolating the rest. And I think that was just a beautiful example of that. What I love, and I've heard you talk about this before, is what do you call it? The most evil, is it the evil muscle of the lower body? I know you said the deltoid for the top, but we've got the TFL for the bottom. And I've heard you talk about that, and I've just found that in my own experiences too. And I seem to find it more on females, to be honest, where they'll just be limited in their external rotation, and then their TFL.
Femoral anteversion.
Okay.
Do you know what femoral anteversion is?
Yeah, so they won't really get much external rotation from the angle of their femur. But you can release, say you take a bit of tone out of the TFL, whatever that is, and they get a lot more back. But I wonder why is that happening? Like why is it trying to abduct for a glute mid that's not doing the work with it? Like I'm unsure,
Well, what you need to do is somebody, and you're right, more women have femoral anteversion than men. In fact, if I see a man with femoral anteversion, I take a picture.
Right.
Because it's so rare, so unusual. And so structurally, they don't have lateral rotation. I mean, it'll be limited. So what you need to find out is what's their neutral. And then the amount of, they'll look like they're in medial rotation, but it's their neutral.
Okay.
And the way you find out what their neutral is when the greater trochanter is pointing laterally.
Oh, that's gold. It's obvious.
Oh yeah, that's obvious. Yeah.
Yeah.
That's cool.
And men more often have femoral retroversion.
Mm-hmm.
So they have a lot of turnout,
Mm.
but they don't have much turn in.
Yeah. That's me.
Mm.
Well, keep it that way, because if you try to change it, you'll be seeing a hip surgeon.
Yeah.
Yeah.
Yeah. And in fact, there's I call it the femoral medial rotation syndrome. That's very interesting because it looks like you exercise.
Mm-hmm.
And um, and so what happens is, you mentioned the TFL.
Yep.
So you must know it's immediate. In fact, the guy had the knee pain because when he was rotating, if it was his right knee, if he's rotating to the left, he's going into hip lateral rotation, and the TFL won't let him.
Yeah.
And so his knee has become moves more readily, because when your femurs are loaded, you've got much less range. And if the muscles are hypertrophied, you don't have any range. That femur is going to move with you right away.
Mm-hmm.
And so there are two things down the kinetic chain that are going to make a difference. One, your knee, or your foot. So some people get a really pronated foot, and that's because their knee isn't too flexible. If they have a high instep and a rigid foot, it's going to be the knee.
Yeah.
Yeah. So the syndrome I was going to tell you about is related, because when people do it, like, are hypertrophying or coring the core, whatever it is now, they if you get the TFL really hypertrophied, when you're standing or your hips extended, it's going to hold it in and let's start with, you have femoral retroversion.
Mm-hmm.
It's going to hold it in medial rotation because that muscle is so overdeveloped. If your gluteals are similarly overdeveloped, when you sit down, it's going to also hold it in medial rotation because the gluteals are going to pull it that way.
Mm-hmm.
So these people get hip pain because a hip that should be sitting in what looks like lateral rotation is always sitting in medial rotation.
Yeah. Okay.
And that starts to injure the hip joint structures itself.
So in regards to so it's a movement, there's a movement somewhere in their life that they're hypertrophying the TFL, and is that what you would go through in your
the
assessment?
TFL is so easily hypertrophied. It's really interesting to me because it's such a wimpy little thing.
Mm-hmm.
And you think, how can it cause so much trouble? But if you scratch the bottom of somebody's foot, the first muscle to go off is the TFL.
Okay.
The first paper written about hip abductors way back when showed that most often the first few degrees of hip adduction, controlling that, is from the tensor fasciae lata.
Right. Okay.
And it starts until the iliotibial band, and the gluteal muscle, the gluteus maximus, also has a big insertion into the iliotibial band. But and the only super evidence I have for this is one of the faculty was doing research on the hip, and they were doing MRIs, and it turned out that one of our students did not have a tensor fasciae lata.
Wow.
We let her stay in school anyway, but anyway, and she was very athletic. And so I ran through all the tests looking for the TFL problems. She had none of them.
Mm.
So that was my N of 1 support that indeed this little wimpy muscle can cause a lot of trouble.
Yeah. Yeah.
Mhm.
That's it's so interesting because I've always just wondered why it's it's become so used in people, and I always think like why is that doing, if they were in more of an anterior tilt, would that prime the TFL to do more?
Well, they could be in an anterior tilt because of the TFL.
Yeah. Okay.
And that's because, as you say, it's a medial rotator. It's also an abductor. And I think it gets particularly hypertrophied or used because it's so part of a daily movement that we do all the time. Flex our hip, stand on it as an abductor, do medial, particularly in women, medial rotation, because to be a real lady, you have to put your knees together.
Yeah.
Go up and down. Of course, now we all wear pants, so it doesn't matter.
Yeah. So, I watched in that assessment how when you were I think the first thing
Let's
you
see
looked
what-
at when you looked at this guy was, okay, he has a lateral pelvic tilt. You saw that his left ilium was a few degrees higher than his right. And then when you widen the legs apart, it
Yeah.
I believe it may have fell even, right? So when you're,
You know why?
because the TFL,
TFL,
is
yeah.
slackened and it's,
Exactly.
Yeah.
You got it.
and
That's where the stiffness. Now wait, let me just
Yep.
interrupt you for a minute, because that's where the stiffness comes in. In other words, both TFLs are not hypertrophy to the same amount.
Mhm.
So when the iliac crest is high on one side, that hip is in adduction. So that TFL isn't as stiff as the other one.
yeah,
Mm-hmm.
okay,
And so then you put your feet apart, you take the stretch off of the TFL because it's an abductor, and the pelvis goes level. It also supports that it's not a leg length discrepancy.
right. Oh, okay, because if it was a leg length discrepancy, it would be the same ilium.
still
It would
be
be,
fine.
be the tilt, yeah. So therefore, say if the left ilium's higher, then you would suspect, if it all followed, that the right TFL would have more stiffness, therefore pulling that side down, which would lift the left side up. Yeah. Okay.
Well, yeah, it pulls down. It's holding more in abduction, and the other one is not holding its abduction as much. So it's
Okay.
an adduction, relative adduction.
Okay.
And the thing, this is probably somebody that had back pain.
Yeah.
And the reason why, also that often will take the back pain away. And the reason why is that when one iliac crest is higher than another, you're in a side bend. Your spine is curved.
Mhm.
And if you have a lot of muscle in particular, I call it squeezo-smasho. Because the hypertrophy of the abdominals are going to add to the compression of the spine. So you're taking something that's not lined up as well as it should be, and you pull down on it, it's going to hurt.
Mhm.
And if you decrease that curve by putting the feet apart so that the pelvis is now level instead of A level, then it can take the pain away.
Do you see it's often like usually TFL and lower body muscles rather than like the QLO or the lat hiking the pelvis? Like,
Well, the lats wouldn't hike the pelvis. Not
Well,
really.
if they're
I confess that I have been negligent in worrying about the QL.
yeah,
I just have to say, mea culpa, mea culpa. I have not spent a lot of time figuring it out.
Mhm.
But I will tell you that it may be in an athletic population, and depending upon what sport it is they do, that it's much more about TFL affecting the pelvis than the QL.
Mhm. Yeah. Okay, that's interesting. Yeah.
And you can kind of tell because that would be a side where if it wouldn't matter what you did, it wouldn't go down. And then if you kind of help to push the down, you can feel the resistance. It would be if they were laying on their side and they do a leg lift from the side, their pelvis will tilt and it won't go down all the way. So there are other signs that help to sort that out.
Okay. Yeah, that makes sense. Yeah. God, that's
The other thing, as long as you're talking about the TFL, that's interesting is, so one of the big things that in the young adult hip pain, that's a big deal right now. Do you know about that?
nah, but I'd love to know more about it.
They call it FAI,
Oh yeah.
femoral acetabular impingement.
Yep.
And so in that condition, the head of the femur is too big or the acetabulum overlaps too much.
Mhm.
Okay. So usually hip flexion is limited to about 90 degrees. When hip flexion is limited that much, the iliopsoas doesn't get stronger very well. And so the TFL will be doing all the things that the iliopsoas should be doing.
Right. Yeah. Wow. Okay. So, and that's just a structural thing.
Yeah, it's your parents' fault, and it's too
Yeah.
late to go back when you find out.
Yeah. Yeah, it makes me think. I remember I saw this younger kid, and whenever he
Well,
ran,
let me correct that. Let me correct that. What they're showing now is that kids that do intensive sports while there's still the bone growth taking place. They're the ones that seem to get an enlarged head of the femur.
Wow.
Yeah.
Okay. Yeah.
Cool.
Yeah. Wow. Yeah. I remember I saw this kid, and every time he ran, it was just complete internal rotation. Like, you know how you see those kids sometimes, and
Now he probably has femoral anteversion. If the feet fly out to the side, the femurs meet. That usually goes along with having femoral anteversion. You should have taken a picture.
yeah. Yeah.
Oh, and to finish it up, it's not unusual for women to have femoral retroversion.
Oh, really? Okay.
I wouldn't have taken a picture because that's not uncommon. It can be.
Yeah. Right.
Cool.
Yeah. I in regards to when you're, say, standing, you're separating their legs and bringing them together. Is that also, what other information can you take from that besides the TFL?
Well, as I say, a leg length discrepancy.
Yeah.
And you also know that changing the back alignment is taking away their symptoms.
Yeah. Okay. Yeah.
You know, and then the other things is that other thing that we just talked about that would play a role is if they're trying to rotate, like doing a sport, like you say, and the rotation can't come from the pelvis now.
Yeah.
And they're going to do more in their back.
Mm.
That's why all these, you know, to look at one joint like it's the problem is so naive because all of these things are interactive. And so the big focus of my exam is to see if there's a painful joint, what are all the factors that are impacting that joint to make it move too readily? Like the knee example. You know, I wouldn't just be looking at what happens to the knee. It's got what happens to the hip, what's your alignment like, etc. All of those things work together. What's your foot? If you have a high instep, the chances are your knee will suffer.
Yeah.
Do you know what I mean by a high instep?
A high end step, like, no, sorry, can you explain that?
Yeah, it's like a rigid foot. You see that when you look at their foot, it looks kind of fixed.
Yeah.
There's no pronation. It doesn't give. The arch doesn't give. Now, that also means you can't dorsiflex well.
Okay.
And so if you can't dorsiflex, it makes you hyperextend your knee. The other thing they get is what we call hammer toes.
Oh, yeah.
The reason why you know what hammer toes are?
Yeah, where they like curl in.
Yeah.
They go up like this. And the reason being that if you're tall, like you're tall, if you had a rigid foot, that when you go to stand up, you can't get your feet under you. It's forward of you. So when you get up, you use your toe flexors because you're pulling your center of gravity rather than pushing it up.
Right. Wow. God, I don't know how you slowly figured all this stuff out. There's reasons for everything. It's pretty amazing. Is there like a biggest, like when you think about your career, right? And you're still practicing, right? So.
Well, I haven't gotten it right yet.
Like.
No, I'm still teaching, but I'm not. I see a few people just on Zoom because I'm not traveling.
Yeah. What were like the biggest breakthroughs that you feel like, oh, that was a huge moment in my career, or that knowing that now is a huge moment, or I'm glad I know that? Like, was there a few times that you can reflect on to think that was a big step in awareness in my career?
I think I'm kind of a slow worker. It was a matter of seeing the forest to figure out which tree is the big one. Like I would put everybody on their hands and knees, and I didn't know what I was looking for until I finally figured out what I was looking for. But it wasn't like aha.
Yeah.
It was like, oh, I'm getting there. I'm getting there. I'm getting there. Yeah.
Okay. And so, because I noticed you put people on the quadruped, and we were chatting about that before, and I've just been curious about what's like all the information you're taking from that. Like, are you seeing when they go into posterior tilt, when the deviation, the medial rotation? Are you just looking at those major things?
Yeah, I even use it for upper quarter.
Oh, really?
The shoulder.
Okay.
Oh, yeah. And just like we talked about before, the big trick is to use the deep muscles and not the big ones on top. So when you're in quadruped, you can load the serratus anterior,
Mm-hmm.
uh, which is key to making your scapula move correctly.
Mm-hmm.
And I can see how it's working. So if somebody gets on their hands and knees and their shoulder blades are standing up, the serratus is not holding it where it should be.
Mm-hmm.
And so, and then you can also see neck problems, because then if they rock back and their neck extends, it means that these big muscles, the neck extensors, the trapezius and the levator scapulae, are pulling their neck into extension, and that's a problem.
Mm-hmm.
So everything from neck problems to shoulder girdle to back to hip, again,
Yeah. Okay. And I'm pretty like into the shoulder at the moment in regards to like
Okay.
upper trapezius and serratus, and seeing the two of them, like when you choose a time, I guess you'll see winging with serratus, but like when it's time to strengthen upper trapezius, because I find a lot of people are weak in upper trapezius, and
How do you decide that?
well, I reference the resting tone of the scapula and seeing if it's sitting in downward rotation in resting, and then the height of the shoulder girdle, if it's below sort of T2 or really drop down low. That's how I'd reference it. But I don't actually do a strength test on upper trapezius. But I've just seen a couple of people that get really bad headaches, and then upper trapezius work was the thing that helped alleviate the tension. So what's your thoughts on that?
Well, I think when shoulders are too low, the upper trapezius is too long.
Yeah.
And so, and the trick is not to have a certain exercise program to make sure that they always keep it up.
Okay.
So like sitting now, and if you were sitting and you're letting your shoulders drop all the time, or when they're doing exercises, do the shoulders go down as they do their biceps curls,
Mm-hmm.
etc. That it's a matter of also making sure that they keep it up. And so it's only a useful thing to get the idea across. So one of the exercises is having people slide their arms up the wall,
Mm-hmm.
facing the wall, slide them up, and then when the arms get to about shoulder level, then you elevate, you shrug a little bit.
Yep.
And then when they've got them up here, you can have them try to posteriorly tilt their scapula.
Mm-hmm.
Okay, so that's lower trapezius.
Yeah.
And then you let them come back down, but you want them to continue to hold this shoulder up.
Right.
They need to learn where it should be.
Yeah.
And I even have people stand around putting their hands on their hips so that they're not letting their shoulders drop all the time. So you have to go into all of their little daily activities.
Yeah. Okay.
That makes sense.
Then the other thing is that's so important, and this is true for neck problems as well, is that the serratus anterior is like a sling. The upper portion is like a sling. So that helps to hold the scapula up.
Mm-hmm.
And you don't want to hypertrophy the upper trapezius so much, because that can create cervical problems, because it attaches to the spinous processes with the ligamentum nuchae.
Mm-hmm.
And if you have people do their shrugging down here, it's going to be rhomboids instead of trapezius up here.
Yeah. Okay. Because I've always wondered why the levator scap on so many people seem to, like, why does that get so tight on so many people? You know?
Because the upper trapezius isn't doing its thing.
Yeah.
I mean, that's a big thing, is you don't look up here to see where things are. You've got to look out on the acromion.
Yeah. To see the angle of the clavicle relative.
And then you want to make sure that muscles like the latissimus dorsi, pectoralis major, are not holding it down
Yeah. Yeah.
indirectly.
I got some gold from your book. You know, when you get the clinical gems from people, like you can obviously go through systems and whatnot, but you get those little clinical gems, those little stories. And it was amazing. And it was something that I feel like I would never see. And I'm glad you saw it first, is how you were talking about winging, but you can get false winging, and how it can be a hypertrophied subscapularis, and it can actually push the entire scapula off the entire vertebral border off, not just the medial angle, if you know what I mean. And then you said you saw that in
Actually, the more correct term is internal rotation.
Oh, okay. All right.
The scapula is in, when the vertebral border's sticking out, it's usually really internal rotation. Anterior tilt will also make it do that, but often it's the combination of anterior tilt and internal rotation.
Yeah.
And what's important for your understanding this is that the serratus is one of the muscles that helps to keep it in external rotation. But it is not effective unless the rhomboids and middle trapezius anchor the vertebral border of the scapula.
Yeah.
Serratus attaches to the scapula, so if it goes flying off the side,
Yeah.
because it's really the only significant abductor of the scapula, then it's not going to be effective. So
Yeah.
you've got to have the right balance between the muscles that fix the serratus vertebral border, like the rhomboids and middle trapezius.
Mm-hmm. Yeah, it's amazing because and then I look at that, and then how you were talking about finding the right balance, and then I remember you were talking about, and I've seen it, how like a scapula, I guess hyperactive or whatever you want to call it, rhomboids holding that scapula into, well, not allowing it to go into upward rotation, and that seems to be some.
Rhomboids won't hold it in upward rotation; they downwardly rotate it.
Yeah, as in they won't allow it to go into upward rotation.
Oh yeah.
Yeah.
Okay.
So, and that seems to be a bit of a common thing, but that doesn't immediately mean that is strong or weak, does it? Say if it's not allowing it to go into upward rotation, and what do you take from that?
I mean, the way I try to assess it is this way. Because the movement of the scapula is so important and it's so tricky, all of those movements that it performs, and yet it's going to, I would say 70% of people that have shoulder problems is because the scapula isn't moving optimally. So to assess what you're talking about, is the serratus just not pulling it, or are the rhomboids holding it?
Yeah.
So I have people, I kind of put one hand here so I can follow as they go up, and the other hand on the inferior angle of the scapula. So if they go up, and I'm trying to help move the scapula at the right time with the arm, I can feel whether there's resistance or not. I can feel whether it moves easily, but it just doesn't move far enough.
Right.
I can feel where it doesn't move, and now it's stuck, and I have to keep trying to make it move.
Right. So you're using feel to,
you put your fingers along the vertebral border, and as they're going up, you go along for the ride. Is this ride easy? Does it go on up, but it just doesn't, the serratus doesn't pull it well enough?
Yeah.
Is it really stiff? How much effort do I need to have to make that scapula move with the humerus? Or it's not going to go.
Oh, I see what you mean. So you almost assist it a little bit and see, it's like not allowing it, or it is going, but there's just nothing taking it there. Oh, another obvious thing.
Yeah, that's cool. That's cool.
It's so good. That's amazing. So Shirley, like for people do you have a online education at all?
Yes, we're doing, because people aren't going to courses anymore. Ever since the pandemic and Zoom, that they can get their Con Ed courses in and not spend so much money or not spend so much time. So I don't blame them. So we have a course that we're doing webinars every week. I mean, not every week, every month. And then in June, we have a 2-day course that's all on Zoom. And then in October, we have a hybrid course. So some people will come in, people that really want to learn the exam, et cetera. And then other people can take it hybrid if they don't want to develop their own examination skills. In fact, this Wednesday, I'm doing the one on, we try to divide up the background information into these webinars because it finally dawned on me, we throw so much information at everybody, they can't sort through it in 2 days.
Yeah.
We're just, and then learn all the other things that we're trying to get them. It only took me 60 years. I don't know why they can't get it in 2 days. So in fact, when people would tell me, oh, I took your course, I say, oh, that's really impressive that you learned all that so fast. I didn't. So anyway, that's what we're doing. That's what I'm doing for WashU. Yeah.
Okay. And what's the website for people to find out more about that?
It's Learn Movement System.
Learn Movement System. Yeah, we'll put it
Learn
in the show
Movement
notes.
System.
Yeah.
Yeah.
And
Yeah.
what I'd love to finish on, just a great question, because like I said, yeah, like it's so inspiring because you're 87, you talk well, you move well, you're still working. It's exciting because there's such a life to be lived, you know. And I think it's easy to see people even in their like 50s and 60s where they just lose quality of life rapidly. They just haven't never rotated over their shoulder 40 degrees in 10 years. You know what I mean? Like no one's just moving as much. And life can be lived. And that's what excites me about it. And so what would you say for the listeners in regards to longevity, in regards to your secrets, in regards to how can we live a long, painful, or at least limiting painful free life to the best of our ability?
Well, I think I was just very, very fortunate. When women weren't supposed to be doing it, I was very active in sports.
Mm-hmm.
So I had maximum opportunity to sort of build myself up in ways that women weren't doing at that time. And in sports also, like we were talking about before, I do a systematic exam so I can assess people. Playing sports, I also learned a lot about people. I mean, I'm sure you do too. If you watch them, do they take winning? How do they do winning? How do they do losing? Are they trying to get better? Do they blame other people? Are they constantly practicing to get it better? So you at that point you start to learn a lot about people, and that proves to be very useful in it. And then finding the profession that really worked well for me.
Mm-hmm.
I mean, I wanted to be physically active, and I started with polio because I couldn't imagine what it was like for these little kids that were paralyzed not to be able to be physically active.
Mm.
And and then I was very fortunate in that I got a position at Washington University where it was all about uh, going higher, learning more, being better
Mm-hmm.
in multiple ways. So I was inspired to do that and just keep thinking about things because there was enough time. And with my own program, here was another thing that was very fortunate in my life. Um, when I went to Washington University, they they were in the Department of Preventive Medicine, which was way ahead of its time because it was about exercise and nutrition. Like, whew, nobody cared. And there was a physician there by the name of John Hollisey, and he was doing what we call translation research. He was looking at the effects of exercise on rats as well as on people and putting it together. And he was the one that really said lifestyle has so much to do with your health.
Mm.
In my day, it was like you just got the diabetes, you just got the hypertension,
Yeah.
and you hope the doctor could give you something for it. Not like you're too fat or you don't exercise enough. And it was clear that exercise was important, and it was clear that cleaning up your eating habits was important.
Mm-hmm.
And and then I had a good background already for being able to do that. And in some ways, I didn't have any major structural problems.
Mm-hmm.
So I started jogging then, and that I always say that's when they looked at you strange because you were rather than because you weren't, because you were jogging. It's
Yeah.
like, what is that
Wow.
old lady? What is that lady doing?
Yeah. Wow.
Now they look at you strange if you don't jog.
Yeah.
So it was finding the profession that worked well for me, having opportunity to keep intellectually growing. There were students and they'd come in and say, well, what are you doing that for? Or how do you do this? So that was challenging, getting involved with the faculty and the teaching things, the opportunity for a PhD,
Mm.
which made me learn a lot about the nervous system that actually has worked better with the musculoskeletal thing than it did with the neurological patients.
Yeah.
So, and I've maintained a little exercise program. I walk at least 3 miles a day still.
Wow.
I do have a cardiac problem, so uh, so be it.
You're Doing bloody well, I'll tell you that.
Yeah, doing awesome. It's
Yeah,
inspiring.
I am. In fact, I had an appointment with my hematologist now they call them providers because you don't see a doctor anymore. You see a nurse practitioner.
Right.
Is it like that in Australia?
I'm not sure, to be honest.
No,
I don't
still
know.
doctors here.
Yeah,
eh?
it's still pretty doctory.
Yeah.
Yeah.
But there's
You see
good,
doctors.
there's
now.
good
Yeah.
and bad ones, definitely.
Yeah, it's
Well, it's just a matter they have 8 minutes a patient,
Yeah.
yeah.
and so anyway, I mean, in this country, um, we don't have what they call socialized medicine, so it's all about making money.
Yeah.
And because they're making less per person, they've got to have more persons.
Yeah.
Yeah, okay.
But anyway, to go to my story is that when I came in and the nurse practitioner said, "You look better than people half your age."
That's so good.
So I took that as a big compliment.
Yeah.
Yeah.
I
I can. It's like you said at the beginning. I am so fortunate. I've traveled all over. I've had a wonderful life. I've enjoyed every minute of it. I've had great colleagues. I mean,
yeah.
they're all uh, 15 to 20 years younger than I am, but we're super great friends. We've worked together for 30, 40 years.
Yeah.
Amazing.
Always pushing back the frontiers of ignorance, trying to make it better. So it couldn't have been. It couldn't be any better.
Something that you said before, and it's inspired me, and it's sort of like, all right, how can I help influence the world? How can I work towards that? Is you spoke about how people go get their teeth checked a couple times a year. People go get everything else checked, but nobody gets their body checked or their body assessed. And that's going to be a debate because there's a whole lot of people in the industry that say posture doesn't matter and all that, you just got to move. And I see that as people that haven't seen it. It's like telling me the sky's not blue. When you see, it's like it's obvious, but they're sort of out of their field. So they're looking towards papers to say that a downward rotator scap doesn't matter, or that forward shoulders don't matter, or forward head. When anatomically, if I think about it like an engineer, there's a perfect spot for things. That makes sense with stress on structures, and I know they won't be able to quantify it because some person could have that downward rotator scap, eat great food, sleep 8 hours a night, have meaningful purpose in life. Someone could have that downward rotator scap, sleep 3 hours a night, eat shit food, and they might feel the pain because they won't regenerate overnight. And that to me is something that I reckon is such a really cool idea. Because when you said that, I was like, that's necessary. There needs to be a clinic of that, or the norm, or a place that people can go to. Because there's not a place that people can go to. If you go see a local physio here, they're not going to look at posture because a lot of them are going to say the same thing. It doesn't matter, just keep moving. So I think, like, I always wonder how does the world do that? And I guess it happens from education and looking into your work and doing these courses and then creating it themselves. But I wonder how, and I don't know yet, but that's a bit of a goal if I can somehow influence people to go get their body checked, because it's fun.
I'll just say that it's a little bit of what you started out with, and I think the same thing applied to nutrition. Is that you just walk because that's what's natural for you.
Yeah.
And they don't think about that there's ways to optimize what happens to your body. I mean, wearing slides changes your gait, how you walk. Do you know what I mean? How tight your pants are changes how you walk and how you sit. So there are many aspects to life. And what sport do you pick out? Like we talked about femoral anteversion, and that girl wants to do ballet. Not a good plan.
Yeah.
And so matching up, being able to, as you say, and that's the tricky part. What are their structural variations? What do they do? How can we optimize that so it's not working against them and works for them? But it does take some knowledge.
Yeah. Well,
sure.
all my boys are getting into golf at the moment, and I have no internal rotation. So I'm like, I don't know about this one for me.
Yeah,
Turn
it
your
hurts
feet
my
out.
back. Yeah.
Turn the feet out.
Don't turn the feet out.
Okay. Yeah. And that'll make it come more from the. I guess it'll give me more range, won't it? Yeah.
Yeah, because you're going to where you should go rather than trying to go where you shouldn't go.
Yeah, I know. Some golfing coach is going to tell me, "What are you doing? Point your feet straight."
Saving your hip. Just tell them you're saving your hip.
Yeah. Yeah.
Or so that you aren't a Tiger Woods who destroys his knee.
Yeah. Right. Yeah. Wow. Well, thanks for coming on, Shirley. I'm definitely going to. I'm heavy into book at the moment. It's one of those books. It's like I can't just read from cover to cover, but I'm opening it up.
I know.
I'm letting contents guide, like my curiosity guide, and I go and I read on stuff. And it's like you get these little gems and exciting, and you got about 90 minutes of brain power in you, because as you read a page, it's like you got to stop, think about. All right, like it's not just like reading a book. It's like there's like imaging going on in your head the entire time. But I feel so uplifted by it. And it's tiring though, but I love it. I love it. So I've definitely put a lot of people into your stuff locally around here, and especially after this podcast. And for people listening, your movement routine, Tim Ferriss put that up on YouTube, basically of what you do. And that's out there on YouTube, so people can find that, and we'll link that in the show notes. But yeah, it's a dream. And thanks for coming on. And it's so cool that, you got a legacy. You got a legacy that a couple hundred years from now we'll be talking about. And I'm thankful for your work in the field.
Yeah, appreciate it. Thank you so much.
I appreciate all your kind comments and your interest in what we're doing.
Yeah.
So thank you.
Yeah. Thanks for coming on. All right. I'll hopefully see you again one day when I fly over to the States and do one of your courses.
Okay, you have to get to the middle of the country, though. It's not very exciting.
I'll make it happen. As long as I've got some coffee, I'll be right. Thank you.
Okay, thank you all.
Bye.
Bye-bye now.